Okay, excellent. Thank you so much. Well, thank you so much for the opportunity to speak with you today. As a physician who spends the majority of his clinical time managing people with kidney disease, I'm excited to talk about this topic, but also because it addresses my other passion, which is addressing healthcare during humanitarian emergencies. So I want to start by introducing you to a man I met in Gaza in March of this year in one of the dialysis units, one of only two dialysis units that's still functioning in Najah Hospital in Rafah in southern Gaza. Now, Ahmed wasn't originally from southern Gaza. He was from northern Gaza initially. And in September 2023, he was going to this facility, the Indonesian hospital in northern Gaza, 3 times a week for his dialysis treatments. These treatments kept him alive. And although he sometimes suffered cramping in his legs during the treatments, he was otherwise tolerating his treatments very well and was able to continue his work as an engineer and to support his wife and children. However, in November of 2023, this hospital was destroyed after an Israeli raid, and the dialysis unit was no longer accessible or usable. Recognizing that he would die without his dialysis treatments, Ahmed and his family migrated south to Gaza City, where he hoped to undergo his dialysis treatments at Shifa Hospital. Unfortunately, when he reached Shifa Hospital, much of the building had been destroyed. The dialysis unit had suffered a fire, and only 5 dialysis machines were still functioning. Water and electricity were not reliable, so the dialysis unit ultimately shut down, and Ahmed quickly had to find another facility to get his life-saving treatments. So he and his family moved here to Deir al-Bala to access the Al-Aqsa Hospital dialysis unit. Now, in September of 2023, there were 5 outpatient facilities for people in Gaza to receive their dialysis treatments. But by the end of November, the 2 largest facilities had been destroyed, leaving only 3 facilities for over 1,100 patients. This meant that dialysis treatments were rationed. In September, Ahmed received 12 hours of dialysis per week, split into 3 treatments of 4 hours. By late November, he was receiving only 2 treatments of 3 hours per week, basically half of what he needed. And this reduction in dialysis increases mortality, but also significantly increases suffering. By January of 2024, he was regularly suffering from nosebleeds, severe pruritus, nausea every morning, limited appetite. All of these are symptoms of having insufficient amount of dialysis. He knew he was slowly dying, but he was still desperate to receive as much dialysis as was available, again, for him to survive. Now, Dr. Lang spoke of the shortages in medications and the wonders of the NCD kits, but certainly, we did hear about the limitation in opiates. There's also significantly limited access to medications to treat non-communicable diseases that are very common in this patient population, such as hypertension, diabetes, and chronic kidney disease issues related to bone disease. Those medications are essentially non-existent. So back to Ahmed, unfortunately, in January and February of 2024, Israeli military incursions into the Al-Aqsa Hospital, with arrest of many of the physicians, forced that dialysis unit to close. It ultimately did reopen later in February, but it was temporarily closed. And patients who were receiving their dialysis treatments there, again, like Ahmed, desperate to survive, he and his family migrated again, this time to Najah Hospital in Rafah. And this is where I met him. So this is a picture of Najah Hospital in southern Gaza from 2020. And what you're seeing is people in front, locals from Rafah, and they're out front with signs complaining that the hospital is too small for Rafah. This was 2020. So you can imagine in 2024, if the hospital was too small in 2020, it's definitely too small in 2024, where there's now about 1.5 million people You know, 70% of the population of Gaza has been forced to migrate south, and the majority, of course, resides in Rafah. Now, when Ahmed arrived here in February of this year, there were 615 patients receiving their dialysis treatments there, even though the dialysis unit in September of 2023 managed only 115. So more than 5 times their initial capacity. And since there were more than 5 times the number of patients, the dialysis unit had to cut corners. Firstly, the dialysis unit never closed. Typically, dialysis units close for about 6 to 8 hours a day so that the water system and machines can be thoroughly cleaned. By running the unit continuously, this dramatically increases the risk of bloodborne infections, including hepatitis B, hepatitis C, and bacterial infections. The second issue is that the amount of dialysis provided to each patient was also dramatically reduced. Consider that Ahmed was receiving 12 hours a week in September 2023. Now he's receiving 2 treatments a week of 2 hours each, so approximately a third of what he was receiving previously. Now, at this time, Ahmed was getting daily nosebleeds. He couldn't sleep at all because he had diffuse and severe pruritus. He was up scratching all night, every night. He was accumulating fluid everywhere. He had severe fatigue, no appetite, and he was waking up again every morning feeling nauseous. He wasn't getting anywhere near enough dialysis, but he was lucky to be getting as much as he was receiving. And he would say to me, "I'm lucky to be alive." And one can think about that emotionally, but I think about it academically. You know, was he actually lucky to be alive? Or, you know, placing it as a scientific question, was it improbable for him to still be alive? What was the probability of his mortality within a year? And so we've established from a fairly wide range of studies that the 1-year mortality for hemodialysis patients is about 7 to 22% in high income countries, and in low and middle income countries is about 20 to 35%. How does this compare with other conditions? And how does this change in a humanitarian emergency? Well, we've already established that even outside humanitarian emergencies, someone who was on dialysis, here represented by the abbreviation HD, and we should be looking at the red bars in the middle of the chart, there's a 5-year survival that is lower than stage 4 Hodgkin's lymphoma. If you're over the age of 55 and on dialysis, your 5-year survival is about as good as stage 4 cervical cancer and worse than metastatic prostate cancer. Needless to say, outside of humanitarian emergencies, the 5-year survival for someone on dialysis is worse than many conditions we very commonly associate with needing early palliative care. Now, within humanitarian emergencies, there isn't good data available on mortality rates of hemodialysis patients. However, I was able to secure some relevant data to extrapolate a 1-year mortality. Now, this data is imperfect. It's really my best guess. This isn't an official way to do it by any stretch of the imagination. You can sort of think of this as a scribble on the back of a napkin approach. So far from official, but it's the best that we've got. We know how many people were on dialysis in Gaza October 1st, how many were on dialysis March 15th, and we know how many people left Gaza. We also know that patients with end-stage kidney disease who are dependent on dialysis usually die within 2 weeks if that dialysis is stopped. So using that data alone, the mortality rate in 5 months is 26.4%, which extrapolates to an annual mortality rate of over 60%, which would be higher than any previously published mortality rate in any dialysis unit anywhere. So even if these numbers are off by a bit, we can certainly say that the mortality rate in a humanitarian emergency of this population is dramatically increased. Now, of course, we're not interested in just the risk of death here. We're also interested in quality of life reductions and suffering. And these are 2 figures that you're likely already familiar with. In a study in the late 1990s in the United States, over 3,700 nursing home residents were followed for functional status and quality of life as measured by the MDS-ADL scale, both before and after starting dialysis. Certainly, this cohort is older than the average or median dialysis patient in North America or even in Gaza. However, this study did provide us with fairly useful information for those of us who practice palliative care medicine. Let's look first at the figure on the left. So what we see here is that functional status was maintained in only 10% of these patients by 1 year. 75% of these patients had died, and the rest suffered significant decline in functional status. Let's go then to the figure on the right. And I think this figure in some ways is more important because it shows that even before dialysis starts, so in our patients who have chronic kidney disease not on dialysis, as they approach dialysis, they are already suffering significant declines in their functional status. This decline in their functional status is equivalent regardless of patient sex, patient race, and patient cognitive status, including if they had documented dementia. This process was still the same. So basically, this is a risk factor for everybody. So let's go back to Ahmed and ask ourselves, well, what symptoms are actually important to impair quality of life? Well, these are roughly the prevalence of symptoms on people who are doing chronic dialysis therapy. And consider these numbers are based on North American units, like dialysis units. So these are patients getting 3 times a week, 4 hours. So outside of humanitarian emergencies where that frequency is often much less. So if you think about it, the most common side effect is severe fatigue. And that symptom tends to get worse the longer one's been on dialysis. And that unfortunately is not something we have good treatments for. However, on this list, there are symptoms that we have good treatments for. For example, the most distressing symptom is pruritus, nausea, vomiting, headaches, restless legs, cramping. These are all symptoms that we actually have treatments for, and both outside and inside humanitarian emergencies that we can focus on to improve the suffering that patients are going through. So then, how do humanitarian emergencies modify our palliative care response, specifically as it relates for patients with kidney disease or patients who have chronic kidney disease? Well, I think the first thing to mention is that displacement, which is essentially ubiquitous in humanitarian emergencies, places a massive amount of pressure on local kidney programs, not just dialysis programs, but it reduces the capacity for care for people who are on dialysis, as well as people with chronic kidney disease not on dialysis. That displacement is not just displacing them from their regular medical care, it also displaces them from their families and from their support networks, which are severely disrupted and also impairs or escalates their suffering. We talked about access to medication being a huge problem, but often in the case of an emergency, patients are displaced from their medication supply at home and often are displaced as far as their access to medications wherever they end up. Ahmed and his family are currently living in a tent with very limited access to any form of healthcare. And so very, very difficult for him to get access to very basic medications even. The other challenge in a humanitarian emergency that we saw looking at kidney transplant patients, and this happens in other areas of non-communicable diseases as well, is that when patients have limited access to some of their medications, but reasonably good access to a limited subset of their medications, is oftentimes they will get massive doses of one of those alternative medications. And transplant is a good example of this. So I saw, for example, a young man in his 20s who had developed Cushing's secondary to very elevated doses of prednisone that he was exposed to for several months at a time, simply because the alternative immunosuppressants were unavailable. And that sort of suffering also we witness. Um, Patients with non-communicable diseases as well, we have to consider, yes, they do suffer from the non-communicable diseases, but it also makes them more vulnerable to the impact of trauma and communicable diseases and infectious diseases. Um, Within the healthcare system, the emergency medical teams in a humanitarian emergency and even the health resources locally are often focused specifically on traumatic injuries. So there's limited capacity to focus on things like palliative care, kidney disease, hypertension, diabetes, and that's something that is changing. Dr. Lang did mention specifically that the WHO role in enhancing NCD response in the response phase of a humanitarian emergency is changing, and it's something that we are seeing as given slowly is being given a little bit more priority. And then, of course, that again mentioning the lack of prioritization of NCDs. So I want to go back and finish specifically on Ahmed and what is our role with him? Where can we intervene and enhance his care? I think I go back and I ask, well, what is our role as nephrologists, right, in palliative care, just in general? And I think, we've been very, very slow as nephrology field to heed the advice that's shown here. So, we started in 1991 recognizing that, as nephrologists, we've always focused on increasing survival with very little attention on quality of life. And that opportunity to integrate palliative care really was focused very limited. And in 1991, even though this was stated, we really were slow to heed this advice. And most of the work in palliative care within nephrology focused specifically on end-of-life care. That being said, of particular importance, in 2000, there was a multidisciplinary meeting with palliative care physicians and nephrologists that really was probably one of the first times precipitating further discussion, meaningful discussion on what is the role of palliative care. Unfortunately, at that time, the recommendations from that meeting still focused specifically on withdrawal from dialysis, and there was still very limited focus on symptoms. That really only came about in 2004. And that was a meeting specifically about how to expand past this problem of looking at palliative care just as end-of-life care, withdrawal of dialysis. And that 2004, I think, was a really important time point because it precipitated a lot more discussion, a lot more research specifically on palliative care and nephrology. And now there actually is a palliative care nephrology fellowship that one can do that's come about in the last 5 to 10 years across Canada and the United States that I think really has changed that impression of being something just about limited to withdrawal of dialysis. And in 2008, I thought these guidelines were specifically pretty helpful because it looked at the total active care of a patient and family, including pain and symptom management, psychological, spiritual, and cultural care. And that was really a moment of really importance, taking it outside of just withdrawing dialysis, looking at bereavement, support to professionals and family cares. That was a really important moment, I thought, and precipitated a lot of growth in that field. And so when I think about, okay, well, what can we do here? What can we do in a humanitarian emergency? Well, I think the first thing is linking family and carers and patients to other healthcare providers that can think about social, cultural, and psychological aspects of well-being. Looking at symptoms, pruritus, dyspnea, chronic pain, nausea, these are very common symptoms, specifically in people with kidney disease and on dialysis, focusing on symptomatic management there. Also, especially in people in humanitarian emergencies who have been exposed to multiple forms of trauma, not just in form of displacement, but also there's multiple other forms of trauma, be it gender-based violence, be it loss of family members, either due to displacement or loss of life. A trauma-informed approach to care needs to be provided. I think as healthcare providers, we also need to be very strong advocates not just for non-communicable diseases. Oh, Megan?
Hi, Dr. Ben. Just if you could wrap up within about 1 or 2 minutes, please.
I will. Yep, this is my last slide. Yep, absolutely. Yeah. So, as advocates, specifically for making sure palliative care is a focus in research as well as in data management with the ongoing emergency plan, medical education of people who are working in nephrology with regards to palliative care. And then, of course, there are the issues about withdrawal of dialysis, bereavement, and end of life care. So looking at Ahmed, I think, all of these issues can certainly be directed towards him. Pruritus, nausea, those symptoms can be managed, providing mental health supports for he and his family, advocate for the national system in Gaza as well as at Najah Hospital to have data management and care pathways for palliative care. Consider bereavement programs for not just his family, but other families. And opening up the discussion. Does Ahmed want to consider withdrawal of dialysis? And is there a plan in place for that? Can we talk to him about the consequences of that? So I'm sorry, I think I have gone over time. I'll end my talk there. Thanks so much.